I have a patient with a cut on her hand that needs a few stitches. It's a simple visit, but when the nurse cycles the blood pressure cuff, the number that comes back is 182 over 112. She feels completely fine. No headache, no chest pain, no blurry vision, just a high number on a machine. Sitting there, silent. And now I have a decision to make that is generally one of the more contested calls in emergency medicine. Do I do anything about that number? Do I start a medication? Do I send her out with a prescription? Or do I stitch the hand, say nothing, and let it be someone else's problem? G'day team, and welcome back to Overheard in the Emergency Room. I'm Dr. Kois, emergency physician and evidence nerd, and this is Overheard Journal Club. Short episodes where I take a single paper that I really enjoyed reading, break it down for you, and tell you how it changed the way I practice medicine. Today, we are talking about asymptomatic hypertension in the emergency department through the lens of a 2024 paper that asks whether prescribing an antihypertensive on discharge actually helps these patients. And I will tell you up front, this is a topic where I have a strong opinion that sits slightly to the side of the official guideline, and I am going to show you why exactly. Before we dive in, hit the like, subscribe, and notification bells. Head over to drkois.com for the companion blog, the full reference list, and a link to the paper. Right, let's go. So let me start off by giving you the scale because it is staggering. Around 120 million Americans have poorly controlled high blood pressure. A third of the country is walking around with a deadly, and here's the key word, modifiable risk factor for the leading killer that we have. And hypertension is not a bystander. Roughly 47% of all coronary heart disease, that's heart attacks, and 54% of strokes are attributable to high blood pressure. Just sit with that for a second. If those numbers do not bother you, they should. Now, here's the emergency medicine problem. A huge number of these people are not seeing a primary care doctor. They are, however, coming to us for a cut in the hand, an ankle sprain, a cough, and while they're in front of us, that cuff reveals the silent number. So the ED becomes, whether we like it or not, a place where a massive public health problem shows up in plain sight. And the tension is this. The ED is not the right place to diagnose chronic hypertension off a single reading. Alarms are blaring, people are stressed out, pain can drive that number up, people are running around butt naked. It is not exactly a relaxing day spa in there. But if we do nothing at all, we may be squandering the one contact this person has with the healthcare system that whole year. So the paper we are looking at asks a sharp, practical question. When we do prescribe an antihypertensive to these patients that are discharged, is it associated with better outcomes? Couldn't think of a better question to ask. So let me walk you through the paper in PICO style: population, intervention, comparator, and outcome. And a quick honesty note before I start. This is not a randomized control trial. It is a large observational analysis. So we are going to be talking about associations, not proof of cause and effect. So keep that flag flying the whole time as we go through this paper. So the population. The investigators looked at an enormous data set, on the order of 26.5 million US emergency department presentations between 2016 and 2019. From that pool, they focused on patients diagnosed with asymptomatic hypertension, and a striking 74% of those ahypertension patients were discharged home. So this is not a rare, sick, admitted population. This is the everyday discharged patient with a high number. The intervention and comparator. The intervention was essentially this: being started on an antihypertensive treatment in the department and sent home with a prescription versus not. And they broke the population into two severity bands, which I think is clinically smart. The first band, systolic blood pressure between 160 and 179, or diastolic 100 to 109, which they called low asymptomatic hypertension. And the second band, that is above 180 over 110, which they called high asymptomatic hypertension. The outcomes. They looked at diagnosis rates, in-department treatment rates, and prescription rates across those bands, and they linked that to 30-day outcomes. In other words, does the person we actually treated and prescribed for do better in the following month than the person we let walk out with nothing? So the results. Okay, here is what the data showed. And honestly, the first thing that jumps out is not the effect size. It is how little we are doing. Look at the low asymptomatic hypertension band, the 160 to 179 group. Only 3.1% were even diagnosed. Only 2.59% were treated in the department, and only 5.84% were given a prescription on the way out. So for the majority of these patients, the high number was quietly noted and then nothing happened. Now for the high asymptomatic hypertension band, above 180 over 110, the genuinely alarming numbers. Here we did a little bit more. 13% were diagnosed, 16.2% were treated in the department, and 8.4% were actually given a prescription. It's better than the low band, but still, even when the pressure is north of 180 over 110, more than 8 in 10 of these patients were walking out without a prescription or a plan. And the headline association. The reason this paper has a title about improved 30-day outcomes is that prescribing an antihypertensive on discharge was linked to better 30-day outcomes for these patients. That is, the people we actually treated and sent out with a prescription tended to do better over the following month than the people we did not. Now, I want to be really disciplined here because this is exactly the kind of result that is very easy to oversell. This is an association. It is entirely possible that the patients who got prescribed were different in ways that made them lower risk to begin with. That is a real and serious limitation, and I will come back to it hard in the appraisal. But the signal is worth taking seriously, especially against that backdrop of how rarely we actually intervene at all. So what's good and what's not? And this is the part of Journal Club where you stop being a fan and start being a critic. And with an observational paper like this, the critic's hat has to be firmly on. So what's good? 1. The scale is extraordinary. When your denominator is in the millions of ED visits, you capture real, messy, everyday practice of an entire country, not a hand-picked trial population. That gives the descriptive findings, especially the treatment rates, a lot of credibility. 2. Splitting the population into severity bands is genuinely useful. It lets us see that our behavior changes with the number, and it lets us reason separately about the merely high and the genuinely dangerous. 3. It shines a bright light on a real care gap. The single most important thing this paper tells us is not the effect size. It's that we are diagnosing and treating a tiny fraction of these patients, even at higher pressures of above 180 over 110. That finding alone should make us uncomfortable, but in a productive way. So what's not so good? 1, and this is the big one, it is observational. It cannot prove that the prescription caused the better outcome. There is real potential for confounding by indication, where the clinician chose to prescribe precisely for the patients they judged most able to benefit or most likely to follow up and get additional support. Association is not causation, and I will not pretend otherwise. 2, a high blood pressure reading on the ED is a lousy way to diagnose the chronic hypertension. Pain, anxiety, and sheer chaos of the department push that pressure number up. A single elevated number is a prompt to investigate, not a diagnosis that can be carved into stone forever. And 3, and this is exactly why the guidelines exist. The American College of Emergency Physicians clinical policy is cautious here. It does not routinely recommend starting antihypertensives for asymptomatic elevated blood pressure in the ED. And it warns that by lowering the pressure too quickly, you could actually cause harm. It does carve out recommendations for certain at-risk groups. So there is a legitimate evidence-based reason to be conservative. And I want to represent that fairly in this discussion because it is the mainstream position. So how do I reconcile a cautious guideline with a paper suggesting benefit? I hold them both. The guideline is right that we should not be aggressively slamming pressures down in the department off one reading. The paper is also right that doing absolutely nothing for the entire visit is also a failure. So then, how should this modify your practice? For the clinicians, this is where I land, and I will be honest that I sit at one end of the spectrum. I think we in the ED have an incredible privilege to help people, and in my experience, it is nearly impossible for a patient who is discharged from the emergency department to establish care with a primary doctor within a month of an ED visit. So to say nothing at all about the genuine elevated pressure feels like a disservice to them. My compromise is not to reflexively start a drug and rush the pressure down. It is to spend a few minutes doing 3 things. First, I teach the patient how to measure their own blood pressure properly and keep a log to bring to their doctor. Second, I walk through the modifiable levers that they can pull on a daily basis, thinking about their body weight, how much they're exercising, making sure they're eating a plant-rich diet that is in keeping with a DASH or Mediterranean eating pattern, cutting out salt or switching salt products to a potassium-based salt, easing off the alcohol and trying to stop smoking cigarettes. Third, and only when it fits, I start the conversation about medication, and I frame this around their values. Rather than issuing a prescription without a discussion for the genuinely high-risk patient or the one in a band the guideline flags, that conversation may end in a script. And one plea, do not let the weird corners of the internet convince your patients that doctors never talk about lifestyle and are just pill mills. That is absolute nonsense. Reading the American Heart Association guideline on hypertension will show you exactly how much lifestyle sits at the heart of proper management of blood pressure. For the patients, if you are listening to this as a patient, here is your action item, and it genuinely is a powerful one. Do not try to diagnose your blood pressure at a noisy pharmacy kiosk or in the middle of an emergency department visit. Instead, buy an inexpensive cuff, sit quietly with your arms supported and measure a set of blood pressures twice a day for 7 days. Write the numbers down, don't panic about a single reading, particularly if you're not having symptoms, then take that log to your doctor. That at-home average is worth more than any one dramatic number, and it turns a vague worry into something your clinician can actually act on. So here are your 3 takeaways from today. 1. Asymptomatic hypertension is everywhere in the ED, and we intervene astonishingly rarely, even when the pressures climb to above 180 over 110. That care gap is the loudest finding in this paper. 2. Prescribing an antihypertensive on discharge was associated with better 30-day outcomes. But this is observational data, so treat it as a strong signal to engage, not as proof that a prescription is the answer for everyone. 3. The move is not to slam the pressure down off one reading. It is to teach home monitoring, coach the modifiable lifestyle levers, and have a values-based conversation about medication, escalating to a script for the right patient. If you got value from this episode, please like, subscribe, and hit that notification bell. Drop a comment below with the next paper you want me to break down. Listener requests always jump the queue. And share this with the one person who has ever been handed a scary blood pressure number and no plan to go with it. Head over to drkois.com to read the full companion blog, reference list, and get links to the paper. I'm Dr. Kois. Let's keep chasing fewer bad days and more good decades together. See you next time, and hopefully not in my emergency department.